Welcome, and thank you for joining us for this presentation about asthma in Indiana and controlling asthma in your life. Funding for this training was made possible in part by the Centers for Disease Control and Prevention. The views expressed in written training materials or publications and by speakers and moderators do not necessarily reflect the official policies of the Department of Health and Human Services, nor does the mention of trade names, commercial practices, or organizations imply endorsement by the U.S. government. The goal of any asthma management plan is to reduce or prevent uncontrolled asthma symptoms, to improve asthma health outcomes, and to improve communication between healthcare professionals, the patient, and their family. Of these three, the most crucial element is to improve communication between everyone involved in the patient's care, because once everyone is on the same page and has a similar understanding of the treatment plan, a child's asthma health outcomes will improve. Research demonstrates the benefit of asthma management plans. They improve lung function, they decrease the number of school days missed, they improve self-efficacy, or the ability to cope with adversity, they decrease the number of ER visits and hospitalizations, and they decrease overall health care costs. So why do we need to increase AMP usage? Well, for a number of reasons. Uncontrolled asthma symptoms and related hospitalizations and deaths occurring each year in Indiana could be avoided if the patient and their family knew how to best handle emergency asthma symptoms or an asthma exacerbation. According to the CDC, the Center for Disease Control, daily and emergency asthma management is best accomplished through the use of an AMP. However, less than half of all Indiana children with asthma have ever been given a plan. Notice that doesn't say less than half actually use a plan, but less than half have ever been given a plan, so they are not even aware that it exists. How can they have the opportunity to use it? Sadly, that's a lot of Indiana children that don't even have access to a plan. Properly using an asthma management plan has numerous benefits for students, allowing them to function better in school, in everyday life, and in other extracurricular activities. We recently met Brooke, an Indiana high school student who has succeeded in sports despite her asthma diagnosis. Let's listen to her story.
Hi, my name is Brooke, and I am an Indiana high school freshman. Outside of my regular classes, I love participating in sports. I have run track, I have played basketball, and for the past 10 years, I've also played soccer. I play 4 times a week and travel with my team weekly. To see me on the field, energetic, competitive, and excited, you would have never guessed that I was diagnosed with asthma at the age of 2. I'm able to perform so well because I have learned how to take control of my asthma, and I do not let asthma define me. Sports are competitive by nature, and in order to compete, an athlete needs to be in good shape and have good lung power. Athletes who have asthma can compete and win as long as their asthma is under good control. When this happens, an athlete with asthma should be able to participate just like anyone else without difficulty breathing. I know many students that have asthma that really want to participate in sports but are afraid of what could happen. And yes, if not well controlled, your asthma can stand in the way of doing things you love. However, many athletes have succeeded despite the diagnosis of asthma. For example, track and field star Jackie Joyner-Kersee is a 4-time Olympian and a 3-time gold medalist, but was diagnosed with asthma as a college freshman. Rams and Steelers running back Jerome Bettis was named Rookie of the Year, played 13 seasons in the NFL, and won a Super Bowl. Most people don't know that he was diagnosed with asthma at the age of 15. Also, Paula Radcliffe is a world record holder in the marathon, but has exercise-induced asthma. She has won the world marathon 7 times. Those are just a few of many athletes that are also not defined by their diagnosis. Like myself, they can control it, instead of letting it control them. One of the first steps to controlling your asthma is to know your triggers. My triggers are spring and fall weather, high ozone days, and respiratory colds. With some athletes even compete when they have exercise-induced asthma. I've learned that staying aware of my breathing and always having my medicines nearby help ensure that I do not have an attack. Since my diagnosis, I have been hospitalized 3 times with overnight stays, but I am happy to say that I have not been hospitalized in 2 years. I regularly have to take my 4 medications, a combination therapy discus, a quick relief inhaler, an antihistamine, and an anti-leukotriene tablet. Though I have never had an attack while playing sports, I do prepare my body for the extra work by taking medications 15 to 20 minutes before practice. Also, I follow an asthma management plan, so everyone around me is aware that I have asthma and they know what to do in case of an emergency. The best advice I received and what I could pass on to someone else with asthma and wants to play in sports is to know your triggers and take your medications regularly as prescribed by your doctor. Gradually work yourself to an exercise level that you are comfortable with, but don't be afraid to push yourself. But know your limit too. Alert others when you are having difficulty breathing, and most important, have fun.
The goal of our plan specifically is to initiate the availability of a uniform, single-page, statewide AMP so we can train all schools and medical personnel on proper usage, either face-to-face or online. We believe proper training will promote consistent use across the state and decrease confusion between patients, parents, schools, and physicians. This approach will ultimately improve asthma outcomes among Indiana residents. This plan represents an evidence-based approach to asthma treatment and the input from community physicians, nurse practitioners, respiratory therapists, school nurses, asthma educators, and school professionals. Through our conversations with NJAC members across the state, we discovered that healthcare and school professionals were using many different types of plans developed from many different resources. Because of this, the process for the AMP's completion is often confusing for parents and professionals. A component of this AMP is the accompanying education and training of all schools and medical personnel on its proper usage. We are committed to everyone involved in the AMP process to have a full understanding of its purpose and how to complete the document. While we are aware that a variety of AMPs are in use, we have found that there are too many. From state plans to national organization plans to local doctor office plans, it's just way too confusing. Over 1 year ago, NJAC convened a statewide coalition of physicians, nurse practitioners, respiratory therapists, asthma educators, school nurses, asthma patients, and their families to offer expert opinion in creating a statewide AMP. This has been a huge collaborative effort on the part of all of our partners, and we are all proud of the final result. Let's now discuss the current challenges of asthma in our state. Approximately 1 in 10 Indiana children between the ages of 0 and 17, that's around 8%, are currently diagnosed with asthma. We are statistically similar nationally with the numbers of people recognizing that they have ever had asthma symptoms, or what we call lifetime asthma. Compared to national data, Indiana has slightly more children exhibiting active symptoms and using medication, termed current asthma. This prevalence of current asthma slide shows the rate of asthma over time. From 2005 until 2011, not much progress had been made in consistently lowering the rates, but the graph reflects the natural fluctuation in disease prevalence. 2011 data is highlighted specifically because of newer methodology in data collection. On this asthma control slide, we are looking at the results of a self-reported study. We see that 27% of the respondents feel their asthma is well controlled. Respondents that feel it is not well controlled is double that, at 54.7%, and very poorly controlled asthma is 18.3%. Because this is a self-reported study, it presents interesting conclusions. A limitation of such a study is that a patient may not know how to identify the true definition of well-controlled asthma. Studies have found that there is disagreement between what a patient may define as well-controlled asthma and what a healthcare provider may define it as. It is a quite reasonable, achievable goal to have the majority of children experiencing well-controlled symptoms. As we look at the prevalence of current asthma among children, we see that between years 5 and 14 it increases. It goes up at age 5 because they are normally starting school and are introduced to a lot of triggers that they had not been exposed to before. We are focusing on the school environment because of the high prevalence of asthma symptoms impacting their school performance. Our final comparative chart will look at the prevalence of current asthma between genders. As of 2013, prevalence among males is higher than that of females. In prior years, the opposite had been true. Now that we've compared Indiana to the rest of the country, let's look at how various counties in Indiana are doing. This slide shows 2013 hospital emergency room discharge rates with asthma as the principal diagnosis in children between ages 5 and 14. The darkest green counties report 500 to approximately 1,200 emergency room visits per 10,000 people. Those counties include Lake, Marion, Allen, Vanderburgh, Jennings, and Howard. The lightest green counties report 175 to approximately 290 emergency department visits per 10,000 people. Some of those counties are LaGrange, Floyd, Dearborn, and Hendricks. Those in white are marked as unstable or they have inconsistent data. It is necessary to point out that some counties do not have the same number of emergency departments as others, so the counties with fewer visits may not actually have a decreased prevalence of asthma if their patients need to go to an emergency room in another county for help. However, this does give us an idea of how widespread asthma emergent symptoms are in our state. Why are healthcare providers in the clinic setting not using an AMP for their patients? Well, that's a really good question. Let's highlight some of the problems in getting the AMP to our children and families. Previously, we discussed that only half of Indiana children are given an AMP, so why not? There have been a few studies that explain, and here are two good examples. Healthcare providers in the clinic setting generally perceive AMPs as useful, but implementation is hampered by lack of training and practice, language barriers, and perceived benefits for patients. Also, qualitative research found that healthcare providers were unenthusiastic about standardized plans for individual patients, preferring to monitor them individually. Let's look at both of these paragraphs. First, implementation is hampered by misperceptions and lack of familiarity with how best to implement the plan into patient care. Language is also a barrier. Our plan is available in English, Spanish, Chin, and Karen. As it's put into use, if more languages are needed, we will have additional translations available. Secondly, providers would rather monitor patients individually, which would be great, but all patients are not monitored individually. Research shows that AMPs are the best option for asthma self-management. It helps patients and families use the same words, being able to advocate and outline asthma treatment plans that are individualized and carried out in settings outside the home, like school and daycare. Are they being given AMPs? As we have stated, no. Nationally, only 25 to 56% of eligible patients receive an AMP. The number one reason patients do not have an AMP is that the clinicians didn't give them one. However, 90% of patients surveyed found AMPs helpful in self-management of their disease. As I mentioned, this plan is available on the website. This plan has been reviewed by the Indiana Department of Education, and the IDOE supports the use of AMPs for students with asthma. At this point, I just want to clarify that this is not a plan that is mandated. It is being offered as a choice. Especially for those students that do not have a plan already, this is a fantastic option for them to use because this plan was developed by a committee of Indiana experts, which included asthma healthcare providers, respiratory therapists, school nurses, parents, the Indiana State Department of Health, and the Indiana Department of Education. And it follows well-researched medical protocols. But if a plan is already in use and everyone involved in the child's care is happy with it, that is fine as well. Who can sign the Asthma Management Plan? This single-page plan actually takes the place of two forms that some schools are currently using. Any healthcare professional with prescriptive authority in the state of Indiana can sign the AMP. It is both a prescribed plan to manage a student's asthma and in order to dispense medications such as albuterol. And at the bottom is a space for the asthma care provider's signature. Again, it has been translated into languages most used for our state: English, Spanish, Chin, and Karen. Now for the fun part. Let's discuss the plan itself. First, let me point out that if you have seen AMPs in the past, the green is usually on top, then yellow, then red. However, ours is flipped with the red on top. We did this for two reasons. One, because we wanted to mirror an actual traffic light that is red, yellow, and green. Two, because we want the user to be able to quickly identify the more severe symptoms first, so you will immediately know if the child is in an emergency situation. This way, you can either identify or rule out the worst symptoms first. We are taught to stop at a red light. Following this plan, it is in the child's best interest that you stop long enough to act promptly in the care of the child. The top portion, as indicated, is to be filled out by the parent, the student information, and contact information. The top portion, as indicated, contains the student information and contact information and is to be filled out by the parent. The largest portion is to be completed by the asthma care provider or primary physician. The first box you see is a box for the rescue or quick relief medication because, again, this has prescriptive authority. So this box is the first thing the physician will be asked to fill out. It is intended to stand out so that everyone knows which medication is needed for when there are problems. Now we will look at each component of the plan in detail. First, we have the red zone. Here, there are emergency signs and danger signs. Any emergency signs should cause you to call 911. Blue or gray lips or fingernails, trouble walking, loss of consciousness, you will need to call 911 immediately. Then there are danger signs. Very short breath, rescue meds haven't improved symptoms, and the student or patient can't do the usual activities. It is important here to remember that prior to calling, tend to the child by administering the emergency medications first or as you are calling. The treatment does say to give rescue medications. It specifies how many puffs or nebulizer treatments to give and to call parent or physician. This is an effort to increase communication, which, as we mentioned, is one of the goals of this plan. We want school nurses and parents or physicians to be in contact at this point so they will be on the same page and will know that the child has been in the red zone. One of the last symptoms in the red zone danger signs list is that symptoms remain the same or get worse after 24 hours in the yellow zone. This is there because in the yellow zone, it states that if symptoms are not gone after 2 or 3 days, to move to the red zone. They are not to stay in the yellow zone for more than 2 or 3 days, and they need to be moved to the red zone and treated accordingly. If they remain in the red zone, the physician should give further instruction to the patient and their parent. We have really tried to make this as step-by-step as possible in regard to the appropriate treatment for each symptom a child is displaying. If you are unclear on the correct usage of an inhaler, the following videos, produced by the Centers for Disease Control and Prevention, will be very helpful. They will demonstrate the proper use of an inhaler with and without a spacer. Yellow means caution. These symptoms may include cough, wheeze, chest tightness, shortness of breath, waking at nights due to asthma, or the ability to do some, but not all, usual activities. These children are probably going to be able to participate in school, but need coordination to figure out how they can function optimally. When in the yellow zone, the caregiver should continue daily controller medications, giving rescue medication per physician orders with 1 minute between puffs, or administer 1 nebulizer treatment every 4 hours as needed. After you have administered the treatments as stated, wait 10 minutes and recheck symptoms. If the patient is not better, go to red zone. If symptoms improve, the asthma management plan will indicate if the student may return to class or normal activity, or it will give other directions. Notice there is a blank after if symptoms improve, may return to class or normal activity. At that point, the doctor can specify any other modifications for the student. The next line, for parent or school nurse, if needed, coordinate rescue medications. The reason we included the phrase if needed is because every school or district may have different rules regarding when to contact the parent if a student comes to the nurse's office. Now we are at the go zone, the green zone, the all is well zone, where there are no symptoms and the child can perform regular activities. No rescue treatments are needed. However, there is a space for a medication in preparation for successful participation in physical ed or sports or recess for the provider to prescribe. This may or may not be the rescue medication. As long as it is used to prevent the onset of symptoms, its use keeps the child in the green zone. We also try to leave enough room for the doctor to include any additional notes specific for that student, or they can just attach an additional sheet if there are more instructions that cannot fit on the page. Because this is essentially taking the place of 2 forms, it is a lot of information. We realize that. So if a doctor needs to attach another sheet to include specific patient information, that is an option. The list of daily controller medication is intended to help the communication process. If a child comes into the yellow zone repeatedly or remains there, it may be because of underuse of the controller medications. Some students may be able to use their controller better when administered before and after school. This section will help underscore for everyone the importance of using the daily medication. Under the green zone, there are more statements we are asking the physicians to make note of. 5 more statements to be exact. The first statement is telling the reader that permission is given to administer medications as instructed in the red-yellow zones. Second, we are asking if the patient has been instructed in the proper use of all of his or her asthma medications. If so, it is the physician's opinion that the student can carry and use his or her inhaler at school. Notice we underline the words can carry and use his or her inhaler at school. We realize that all schools do not allow students to carry inhalers, especially depending on the age. So if they are allowed to carry it, then they can. Next, the physician may indicate that the student needs supervision or assistance to use his or her inhaler medication. Also, the physician may indicate that the student should not carry his or her inhaler while at school. Lastly, they will indicate if they are to use a spacer with their inhaler medication. It is our hope that asking the physicians to check one or more of these boxes will provide clarity on how the students should go about getting their medication if they need it. Under those permissions, there is a space for the physician's signature and the date. Additionally, there are parent permissions. In order for this one form to be used by schools as the medical treatment orders and as the parent permission form, signatures are required from both the healthcare provider with prescriptive authority and the parent. It reads as follows: I give permission for the school nurse and any pertinent staff caring for my child to follow this plan. We included the words "and pertinent staff" because we do realize that all schools do not have a full-time nurse on staff, and there may be times that the student is not in the care of a nurse, so this does cover all staff. It continues with, administer medication and care for my child, contact my asthma care provider if necessary. Again, we are trying to bridge the communication gap to enhance the coordination of care. It ends with, and for this form to be faxed or emailed to my child's school or be shared with school staff per FERPA guidelines. I assume full responsibility for providing the school with prescribed medication and delivery or monitoring devices. After that, there is space for the parent's signature and date. What are FERPA guidelines? FERPA stands for the Family Educational Rights and Privacy Act of 1974 and is a United States federal law. FERPA gives parents access to their child's education records, an opportunity to seek to have the records amended, and some control over the disclosure of information from the records. The law applies only to educational agencies and institutions that receive funding under a program administered by the U.S. Department of Education. We are happy to report that there are some school districts already using the plan. This certainly speaks to the need that some school nurses have had for it. Here are some testimonials that have been shared with us. I have shared this with the other nurses in our corporation, and we are excited about the possibility of using this one form in place of our two that we are currently using. I had a case where I needed a plan and sent a copy home with a student. The doctor's office called, and we were able to communicate well because we were talking about the same plan. I also love that the red zone is first up on the plan. Genius. What do we expect to come out of the usage of this plan? To improve communication between school nurses and healthcare providers about students' asthma. To increase utilization of AMPs by healthcare providers, school nurses, and asthma patients. To increase community awareness of the importance of AMPs. Let's pause here so I can again stress that we want to raise awareness about the importance of using any asthma management plan, not just ours. Continuing on, other expected outcomes are to increase education about the management of asthma, even for those that are not currently affected, and to collect data on the asthma management plan use and make it available to other researchers and asthma experts. During the initiation of the asthma management plan implementation, data will be collected for a formative evaluation. We are aware of 6 other states that currently have a statewide asthma management plan, and from the research they presented, they have had positive outcomes as a result of the usage. Ohio, Maine, New Jersey, Maryland, Vermont, and Idaho are those states we are aware of. Thank you for your time, and we hope that you have gained an appreciation for the task we have been able to complete and about the importance of implementing a statewide asthma management plan. If you have any questions or concerns, here is contact information for both the Indiana Joint Asthma Coalition and the State Department of Health.